Good evening. I'm Kelly Geer Ripen, National Chair of A Woman's Journey. On behalf of Johns Hopkins Medicine's A Woman's Journey, I want to thank you for joining us this evening for our monthly webcast series, Healthy Conversations That Matter. You know, A Woman's Journey always strives to improve your well-being through health education. Although the shoulder is the most movable joint in the body, it is also an unstable joint because of its range of motion. The shoulder joint is supported by soft tissues, muscles, tendons, and ligaments, which are also subject to injury, overuse, and underuse. Tonight, we are joined by orthopedic surgeon Dr. Edward McFarland, who is the Wayne H. Lewis Professor of Shoulder and Elbow Surgery and the Director of the Division of Shoulder Surgery. Dr. McFarland will discuss the structure of the shoulder and elbow and what can be done non-surgically and surgically to treat injuries. So please use the Q&A on your screen to ask your questions to Dr. McFarland, who will respond during the last 20 minutes or so of our conversation this evening. Our webcast will conclude at 8 p.m. I want to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for their production assistance, and you can visit their website for additional lectures and courses throughout the year. And now I am pleased to welcome Dr. McFarland. Dr. McFarland, good evening.
Thank you very much. Pleasure to be here.
Thank you for coming.
Well, I wanted to thank Kelly and all the staff for helping me through this with all the computer work. It's always a challenge, but it's a fun challenge. I also should recommend one of the students who helped me get together some of the slides or some of the information, Lawrence Okeke, and he's a third-year medical student going on fourth, and it's done a great job. So without further ado, I'm going to talk a little bit about elbows, but mostly about shoulders. And I'm going to first talk about sort of the natural history of aches and pains around the shoulder and the elbow that many of us seem to get as we get more mature, as I say. And we're also going to talk a little bit about how to prevent them and treatment, what works and what doesn't work. And lastly, a short bit on shoulder replacements and some of the current work we're doing in that field. So a little bit of background, I played football in high school and college, and I was pretty lucky. I only had one injury, but you know, when you're in a collegiate situation or maybe even professional, you get all sorts of great treatment and rehab and attention, and everything's there that you need to get back to play. In my medical school, my residency, though, I kind of felt like that we should treat everybody that way, like older people or grown-ups that want to be doing sports. I thought, you know, they should have the same kind of treatments that I got to get me back faster, and the treatment should maybe be a little more aggressive to get us so that we could do things. So I was fortunate that I was able to train in Los Angeles with Dr. Frank Jobe, who's an expert shoulder and elbow physician, and he and his group piqued my interest in rotator cuff tendonitis and tears and shoulder instability and a variety of other conditions that I've gone on to practice for the past, I can't tell you how many years, but my shoulders are intact. So one thing that I discovered when I got out into practice was that there's really not one kind of athlete like the pros, as you're sort of when you're taking care of them at a collegiate or professional level. So we sort of divide the group into those who are doing intense activities like Ironman athletes or maybe even semi-pros. And then there are those who are doing recreational sports, into maybe softball or kickball or paddleball or such. And then there are those who are just trying to stay in shape, of which is increasingly a goal of many of us who are trying to keep ourselves fit and staying together. So one thing I did learn, though, that as I was in my medical practice was that a lot of these more mature patients were having shoulder issues, and they didn't have any trauma, but for some reason their shoulders started to hurt or other body parts started to hurt. Sometimes because exercise programs were too strenuous, like this young lady who probably shouldn't be trying something like this. And then the other thing too is that when you get a little more mature, you know, we all get these aches and pains, and they don't get better in 48 hours. They kind of have a bad habit of lingering on. And I think that's a little bit different than, when you're 20s and doing post-collegiate sports or collegiate sports, etc. So there are some basic true facts that all of us, as we mature, need to know. One is that the body does not really take to large increases in stress over a short period of time. So if you go do something that you haven't done in 20 years and you do twice as much as you should have done, you can almost bet that something's going to get sore and you're probably going to hurt for days. And even if you are in shape, doing one exercise, a new one will challenge other body parts. So it's interesting that if you're a runner and you go out and ride your bike for 50 miles, you're not going to be able to walk the next day because even though you're maybe using some of the same muscles, it's not at the same angle or at the same degree, and can really be challenging. The reason these slides are here is when I was at the University of Florida, I took care of the swimmers, and a large number of them were having all these strange injuries, like the woman in the upper right was pulling a sled, which is a football thing, and they would get low back pain or even herniated discs. And swimmers don't need that exercise really, or they would be running stairs. And I'm not sure that running stairs has much of anything to do with how well you swim. But particularly because the muscles are used at different angles and different speeds, and all exercise physiologists say that if you want to get good at your sport, do your sport. And so the other thing I found out too was in practice was that people would try to work through things and it would only get worse and worse. And sometimes you just have to know when to cut back. So I came with a sort of idea, good pain, bad pain. Good pain is the burn you get in your muscles when you do an activity and you feel invigorated and you really gotten something accomplished. And each time you do an exercise, you make a little bit of progress and you feel really good about it and you're doing really well and life is good. The bad pain, though, is pain that you have at rest after exercise. So if it hurts for 2 days, that's kind of a problem. Pain that starts waking up at night, also probably not a good thing. Pain that gets worse despite rest. So say you run or you lift weights with your arms and you have some soreness, it should go away within a day or so. But if it lasts for months or years or whatever, obviously there's probably something going on. Also, sort of small aches and pains usually get better with ice or heat or stretching. If it doesn't respond to medication like Tylenol or anti-inflammatories, then probably things are escalating. And if you have to start taking medicine for pains or things that you get with exercise, probably you should rethink your goals a little bit. And lastly, some patients or people who are athletic, they want to take narcotics to be able to play softball or be able to pitch in the softball league. And once you start taking pain medicine, it's really a little bit going overboard in terms of the severity of the injury and maybe when you should seek medical help. So you might ask, what does this all have to do with shoulders? And that is, as we get more mature, our tendons in our body microscopically and physiologically also get a little older. And the tendons and rotator cuff tendons in your shoulder also change. And this is a cellular thing and also changes at the tissue level. Oddly enough, we're not really sure why tendons around your body degenerate, but they probably has something to do with the fact that the cells and the tissues and things all mature, and they just don't take the amount of stress that they took before, and they also just don't heal as fast as they did before. So one of the important things, observations you can make that something's foul in the shoulder is that most big-time athletes, particularly overhead sports, they usually start to decline or peak out in their activity or their excellence in their early 30s. And it just so happens that that's really true for people who aren't big-time athletes. For some reason or another, 30 to 40 is about when things start to unravel a little bit. And it's very, very common, not only in big athletes, but in those of us who try to stay in shape. So there are a lot of non-athletic people who seem to get shoulder problems, even though they haven't really done very much. And the reason for that is that there have been studies that show that over the age of 80, about 50% of people who have shoulder pain have a partial tear of their rotator cuff tendons, or maybe even a full tear of their tendons, and they don't even know it. And so that's the insidious onset kind of thing about shoulder rotator cuff problems. It's a little bit difficult to understand. So for those of you who are not shoulder aficionados, Basically, there are three bones involved. One is the arm, your humerus, and it forms a ball up at the top, as seen here. And then there's the shoulder blade, which has the socket, or the glenoid, it's called. And so your shoulder is a ball and socket joint. And as Kelly mentioned, it has the most freedoms of motion of any joint in your body. And then, of course, the third one involved is your collarbone or your clavicle. And that joint, fortunately, doesn't get injured as much as others. But probably the biggest thing around shoulders, of course, is soft tissue problems. So these two bones meet at the joint, and so it's the glenohumeral joint, or the glenoid is the socket, and the humeral head is the ball. And both of them are covered with cartilage, and that is true for any joint, really, where there's two bones that could potentially rub on each other. And it's basically like Teflon on a ball bearing. It's really the thing that allows it to slide and glide and not and to perform normally. The other thing that is important that Kelly also mentioned is tendons and ligaments. Most people don't, I think it's not uncommon to not know what a tendon is, but a tendon is basically where a muscle turns into a tendon and it attaches to the bone, so that when the muscle contracts, it pulls on the tendon, and the tendon makes the bone on that it's attached to move. And so if they see too much stress, tendons can begin to hurt. And when they get really aggravated, they sometimes can swell and produce fluid. Now, the drawing on the right is actually where, like, say you tear a hamstring muscle, it usually tears where it's starting to turn into a tendon. Whereas in the shoulder, the tendons sort of tear off the bone as opposed to tearing where the muscle meets the tendon. So it's a little different, but all these injuries have little subtle differences depending on the joint. So as you get more mature, these tendons start to slowly degenerate, and this causes them to hurt with too much stress. We're not sure why that happens, but we know that if tendons see too much stress over a short period of time, for some reason they ache and they put off chemicals and things, probably has something to do with the cells. Oddly enough, there's really, when you have achy tendons or joints, a lot of times it's not really inflammation as we know it. It's really there's no inflammation cells, but for some reason it's really considered something that's more of an osis. So we don't call it rotator in the business. We don't call it rotator cuff tendonitis anymore. We call it painful tendinosis, which doesn't really matter very much, but it does in terms of what sort of things you use to try to make it get better. So let's talk a little bit about shoulders again. The shoulder is the humeral head again. It's got a socket. The rotator cuff are muscles that start on the shoulder blade, and as they get close to the joint, they turn into a tendon, and the tendon goes and attaches to the bone, as shown here on the right. And the tendon is actually pretty thick. It's about as thick as your little finger. This is a slice through what the proximal humerus looks like, where the tendon attaches, and you can see that the tendon actually has several layers. On the far right is where the muscle slowly turning into a tendon about the level of the joint, and then to the left side, the blue part is where the tendon is, and you can see that it's actually fairly thick, and that's true of pretty much all of your rotator cuff tendons. They're about as thick as your little finger, maybe as wide as two fingers, and there's one in the front of the ball, there's one on the top of the ball, and there's two in the back. So they form a cuff of tendons around the ball. And so basically what happens is the rotator cuff helps to stabilize the shoulder by pulling it into the socket, and that keeps your arm able to move in space. So if you think about it, when your arm's in real close, the ball doesn't really need to be held into the socket real tightly, but if you get your arm away from your body out like this, and you're picking something up, then the ball actually has to become compressed into the socket. So anyway, so you need your rotator cuff primarily for strength of the arm and the ability to lift things and do things far away from your body or over shoulder height. So how do tendons fail? There's two ways. One is you fall, and the tension from the fall causes the tendon to pull off of the bone. And this is usually a major trauma, like a fall or a car accident or something like that, fall out of a chair or fall out of a ladder or something. And as a result, because people's tendons are fairly good until you hit 30 or 40. Most young people or people who are not really more mature yet, they tend to not have rotator cuff tears. So we don't really even start to see rotator cuff tears until people are in their 40s and 50s and 60s. And the reason for that is that the tendons gradually start to wear out and get thinner and thinner over time. They start to fray. They literally look like fronds of a rope hanging down, and that's called a partial tear. So here's this is a drawing of what a partial tear would look like. Some of the fibers on the inside are starting to pull apart, and it starts to fray. Some people say it looks like they look like outside of a fraying of a rope, maybe crab meat. That appeals to all of us in Maryland, of course. And so they start to just really look very degenerative and terrible. And as the tendon gets thinner and thinner, though, over time, it gets easier to tear. So that's why people with maybe not major traumas in their 50s and 60s, they pick something up and their rotator cuff tears. It's because the tendon is getting thin to begin with. So my favorite is people that put their luggage in the overhead bin. They feel a little twinge, and then they keep hurting and keep hurting, and then they get an MRI and it shows that they've torn 3 tendons, and they probably didn't tear those tendons at the time. It probably was going to fail sooner or later, and that's sort of the problem with rotator cuff tears is they can tear multiple ways. So what happens then is the tendon just keeps fraying and sort of starts to look like the view on the left, where the thing on the right is the tendon, and you can see that it doesn't really attach to the bone. And so on the right side is an illustration of how a tendon gets like a rope. It's like cutting through a rope. It's hanging, as long as it's hanging on by a few threads, it's still going to work, but it doesn't take much trauma to cause it to fail. So there are basically 2 kinds of tears then. One is a traumatic tear where you fall and it rips off the bone. The other is what are called attritional tears, or I call them wear a hole in the seat of your pants tears. You just gradually gets thinner and thinner until there's a hole there and you don't even know that it's there. And usually, in fact, like I said, over 50% of people over the age of 80 have torn rotator cuffs and they don't even know it. So it's unfortunate that for many people, we're not sure why one person versus another necessarily. They have rotator cuff tears, they don't even know it because they don't have any symptoms, probably because they don't do a lot. But the tears are not too unlike this hole in the seat of your pants. It's not that the tissue tore off, it's just missing. And so when you have a tear like this, trying to sew it back together, you can imagine the stitches sometimes don't hold or don't heal. So rotator cuff problems are really of 2 varieties. One, you fall and you tear it off the bone, and the other is you just gradually wear a hole in it like the seat of your pants, and it gets thin enough that it tears, or it just tears and you never know it. So the good news and bad news, though, is depending on your activity, you can actually function pretty well with a lot of your rotator cuff missing. So this young man has 3 of his 4 rotator cuff tendons torn, and he has full range of motion, and he doesn't have any pain. And so you can actually have a pretty decent life without your rotator cuff, but it all depends on what you do, which a lot in turn depends on your age. So there's a couple things you can do to be nice to your shoulders. There's 3 things that are really hard on your shoulders that can cause you pain. And if you have rotator cuff problems, these will make them worse. So one is lifting over shoulder level, over shoulder height, particularly with weights. It's really not good for your shoulders. And if you're going to be doing this kind of thing, you have to do it under the guide of a therapist. Also, lifting far away from your body, like this guy, when your arms are real far away from your body, it puts huge amounts of stress on your shoulder. In fact, if you ever, one of the things that I don't know if you've ever noticed when you're holding a jug to fill with water, and as it gets more and more water and it's harder and harder to hold it, right? And that's sort of just sort of a sign of the stress that doing things far away from your body can put on your shoulder. And then the other things that are really stressful are things that are like planks or push-ups or pull-ups. Planks are not quite so bad because they're not full body weight, but push-ups are particularly hard on your shoulders. So the other thing too is when you do have shoulder pain, one of the things that shoulders do that's kind of ornery is that they get stiff. And so if you're having pain, you don't want to baby it. You really should start range of motion, trying to keep it from getting stiffer, because then you end up with 2 problems. So you really should avoid a sling for pain, and maybe use it on a temporary basis at most, but you want to keep moving your arms And these are some easy exercises you can do in the shower. It only takes 2 minutes. So the other things that you want to make sure that it doesn't, if it is going to hurt, or do things that make it hurt within reason. In other words, if you live to play paddleball and you have some pain afterwards, then there are ways to treat it, but you just have to be careful. So that you shouldn't do any strengthening over shoulder level. The good news is, for most of us, is most of the things we do as we get more mature is we do activities below shoulder level, and though most of those are pretty safe. So oddly enough, you can row down low, but you can't do a push-up, right? So anything up high is really hard on your shoulders. So the other thing is, in you're thinking about treating these little aggravations, ice is your friend. Ice is the best thing for pain relief. You can ice it every 2 hours for 20 or 30 minutes. You can do it all day if you want, but ice is not a drug, and it's really great for joints that hurt or swell. Some people like heat. The heat's usually typically better for doing your range of motion. But in reality, most of the time we just tell people, look, whatever works for you works best. Do that. Get your pain relief and get your motion and try to take care of your pain. Obviously, you can do other things. Tylenol's a nice place to start, unless you have liver disease, and then you shouldn't use it. The other medicines that are called non-steroidals, but they're over-the-counter, ibuprofen and naproxen and those sorts of things, Celebrex. Obviously, if you start using those medications on any sort of long-term basis, you should talk to your physician about it. You shouldn't really take these drugs if you're on blood thinners or have a history of peptic ulcer disease and things like that. Heart failure, those are all contraindicated. Seem to be stopped. Technical difficulties. There we go. So the next step in treatment, if all that fails, is cortisone shots. You can either inject the shoulder in the bursa area, or you can inject into the joint itself. And sometimes they take care of the pain forever, but you have to have a diagnosis. So you have to make sure somebody you're seeing knows what they're doing. And sometimes you can even take a Medrol pack, which is oral steroids, and they're helpful as well. The only caveat about that is, and I'm sure some of you have probably had this experience where your shoulder hurt like Hades for a couple of days, and you have sort of a flare afterwards of pain. That is not common, fortunately, but if it does happen, you need to ice it a lot and make sure you maintain your range of motion. The other thing about cortisone shots is that they don't really heal the pain. So after you have a shot, you should ice, do your range of motion, activity modification, etc. And the final analysis, if it continues, you should determine the cause of the pain and deal with it depending on the severities we talked about earlier in terms of, quote, bad pain. So some of the things that are done these days non-operatively, which are a little bit controversial, they've managed to get a widespread endorsement and use in the medical community. Basically, one is PRP, which is platelet-rich plasma, and plasma is the stuff you get in your blood when you spin all the red blood cells out. And on the right, you can see that there's a centrifuge, and first they draw blood from your arm, they put it in a centrifuge, they spin it down as shown on the left, and there's a tiny little layer of it's rich in platelets, and then it's injected into knees or shoulders or elbows. And it's kind of controversial. I would say that part of the reasons it's hard to study is that there are lots of different combinations or way of preparing PRP. Some show better median interval, or in other words, they don't give you a lot of pain relief right after the shot, but maybe a few weeks later, and sometimes maybe even longer than that. And so how much pain they give it is variable between the preparations. And so it's very difficult to create clinical studies that really prove the efficacy of PRP. It is a good option, though, if you can't take steroid shots or you have other risk factors. There was a systematic review done by this group in just last year, and they concluded that clinicians should use PRP with moderate expectations until more consistent evidence is available. And so for everyone who's not a clinician, those of us who also live in the real world, the PRP, frankly, has mixed results, and And some insurance, of course, insurances don't pay for it for that reason. And it's a kind of a controversial field. Even more controversial is stem cells. It started when a lot of baseball players and others started going to Europe to get stem cell injections, and then it became fairly common. And basically what stem cells are primitive cells that exist in your fat or in your bone marrow, and they're cultured in some media, and then they're eventually injected into the joint with the idea to regenerate the tissue, either cartilage or bone or other things, or even tendons. And the ability of stem cells to do that has come under significant question. Probably there's several issues with it, and this again is another systematic review. And they concluded that evidence based on recommendations for the use of stem cell therapy for tendon disorders in clinical practice cannot be made at this time, which basically means you're paying a lot of money for something that has at best a 50-50 chance it's going to work. And, stem cells are anywhere from $3,000 to $5,000 a shot. And it's really, you're probably better off spending your money on a new car. So what about physical therapy for rotator cuff issues? My advice is if you're going to go see a physical therapist or it's been prescribed before or after surgery or after any treatment, you need to find a therapist who knows something about shoulders. They're obviously very complex. And the other advice is go only twice a week. If you go 3 times a week, your number of visits disappears in 2 months. And you need also to spread out your visits so that between visits, your shoulders have a time to rest. So I always tell patients go Monday, Thursday, or Tuesday, Friday. And that way you have time to recover before the next assault on your shoulder. Also should consider maybe some medicine before or after, and certainly should ice before and after. And probably the best therapist we've learned in therapy is not only address the ball and socket joint, but also address the shoulder blade and how you move and how you sit and those kinds of things. They do seem to have an impact on how you do with rotator cuff problems. So what about surgery for rotator cuff tears? Their rotator cuff surgery actually has a great result for pain relief. Probably 95% of people get pain relief. They're also great for pain in activity, so you can typically get back to your sports. Like say for tennis players, the return to sport is around 80% or so. And the surgery can be done through an open incision, like on the left, and you sew it down to the bone, like shown in the little diagram there, or you can have it done arthroscopically through smaller holes. Either way, the tendon heals back to the bone in the same manner, so it doesn't really matter if you have it done open or through a scope, because the time of recovery is almost the same. And certainly 1 year, the results are pretty much indistinguishable. One thing we do know, though, is if you have a really large tear, in other words, the hole in the seat of your pants is really big, we know that large tears tend not to heal completely to bone. And so people who fall and tear the tendon off the bone, there's usually tendon around to sew. But if you have, quote, nutritional tear, or one where you wear a hole in the seat of your pants, the tear can get so big that there's no chance you can actually sew the tendon back and fill the hole. And so the other downside of rotator cuff surgery, anybody who's had it will tell you this, it usually is pretty painful. And so it's real important to have a pain regimen afterwards, and you have to work real hard not to get stiff. And of course, the other bummer is that over 15 to 20 years, it can re-tear again. Fortunately, that's not that common, but sewing the tendon back down to the bone doesn't change the way it heals. And so you can still go on to have tears in the future, and you have to deal with that the same way you would the first time. So what's sort of new in the shoulder world? Shoulder replacements were developed back in the 1970s. They were designed for people with arthritis or people with torn rotator cuffs. And so it was designed for bone-on-bone arthritis, where the cartilage was gone and the two bones were rubbing on each other, the ball and the socket. And so the indication for surgery was pain and loss of motion and loss of function. And it was pretty good to get people back to doing things without pain, particularly like sleeping and doing day-to-day activities. One of the problems with that type of prosthesis, where the ball is replaced with the ball and the sockets covered with a piece of plastic, is that people who have torn rotator cuffs, those prostheses didn't work very well. So back in Europe in the early 1980s and 1990s, a Frenchman named Gramont came up with this idea that if there's no rotator cuff, then you need to do something to make it so that the arm would still work. So he came up with this idea to put the ball on the other side, and then there's a piece that goes down the arm bone is shown on the right, but the prosthesis itself is shown on the left. And I was doing a traveling fellowship around 2001 or so, and saw these being put in Europe. I thought it was the dumbest thing I ever seen in my life. And ends up that it's now, over the years, has been refined so that it works really great for people that have torn rotator cuffs or that aren't or usually associated with arthritis. And it's now the most commonly used shoulder replacement in the world. So it's kind of amazing. You wouldn't think this thing would even work, but it's actually not probably, it is the most common shoulder replacement done around the world at this time. So it's called the reverse, of course, and it looks funny, but it works great. The other thing that's really great about it is the recovery is relatively fast. So on the right, you see somebody's got really bad arthritis. The ball is flat and the socket's worn away. And you put this thing in there and they actually have pretty good motion, good pain relief. Recovery's fast. And it can be used for a variety of conditions other than just arthritis, such as skeletal dysplasias or sickle cell disease and things like that. So it's really got a lot of versatility. Our experience, we've done about over getting close on 2,000 maybe. And of course, at a referral place, we take on some of the most difficult cases. Fortunately, this is a woman who is excited about her reverse. She has almost no loss of range of motion. So, of course, you always show your best cases, but she's really very happy with the results. She works on a farm and works with dogs, training dogs, or whatever. Anyway, so we also can use this for other ones that have failed. We've got a great experience with this device and have multiple publications, of course, because that's sort of what we do. So just so you don't think I forgot the elbow entirely, the two most common problems in the elbow are pain where the tendon's attached to the bone. And so on the outside where the muscles and the tendons of the muscles attach, on the lateral side is the lateral epicondylitis, but of course it's tennis elbow. And when it's on the inside of your elbow, down where your funny bone nerve is, your ulnar nerve, that's called golfer's elbow. Usually people who get it had neither one of these sports involved. So it can happen to anybody if they do too much too soon or they overdo it or whatever, like we were talking about earlier. It's usually due to some new activity. A lot of people get it gardening. And once it gets settled in there, sometimes it can really be a problem, but it's usually due to overload of some activity or another. The treatment, not too exciting, the same as rotator cuff tendon problems, misspelled problems. Anyway, so ice, you got to make sure you maintain your range of motion. There are some strengthening exercises shown here. You can use a tennis elbow brace, medication, cortisone shots, PRP, all that sort of thing. And the results are pretty much almost the same as you would see in the shoulders. So when you're treating tennis elbow, sometimes it goes away on its own. I've had it a couple times, and if you wait it out, sometimes it just disappears. So the main thing, though, is to adjust your activities. It might hurt. But one thing that's interesting about tennis elbow is it might hurt, but you're not hurting it. In other words, it's not degenerative. It's not going to cause your arm to get arthritis or anything like that. So there's no really long-term issues except that it hurts. And if you do get bad enough to have surgery, the results for surgery are over 90%, but it does take quite a while to recover, usually 3 to 6 months at least. So in summary, I'd like to thank everybody for allowing me to do this. It's been great fun. Hopefully I've saved some of you from hurting yourselves by doing too much. And I have to say that I have the best job on the planet working with these people, and not only to make people better, it's an absolute gift. And these are some of the people from around the world who've come and worked with me. And so it's a great opportunity to teach young people from high school to doctors in practice. That's how I got started with a mentor who was a surgeon, and I appreciate the chance to talk with you and hope some of this will be helpful for you and your friends and your family. But if you need help, there's always somebody there for you, and that would be including us as well. So I hope you have a good hope you've learned something and you have a good time recovering from your shoulder problems. And there are some handouts, not handouts, they're actually on the internet, and I think there's some information that'll be sent to you later that we usually give to our patients. So, all right, Kelly, that's all I got.
Oh, it's wonderful. Thank you, Dr. McFarland. Really great. I was sitting here going, yep, I know what he's talking about on that pain. I want to ask you before we get started on the questions, besides what you mentioned with PRP and stem cell, are there other new advances that are in research right now that you can speak of that would be helpful for, taking care of shoulder pain?
Well, there's always something new on the block. I think, oddly enough, there's in terms of stem cells, there's really, the problem with stem cells is the same with PRP, is that they're all created a different way, and so there seems to be, it's kind of astonishing that just how one is treated could have different results than others. There are some people that are working on ways to maybe reinforce the tendons so that they heal better, but unfortunately, a lot of those with good follow-up have not maintained the things we hoped they would. But there are some grafting materials. We were talking about ulnar collateral ligament injuries earlier. There are some supporting type bands or tissues that you can put there to reinforce the repair. And yeah, so there are some things going forward. I would say nothing earth-shattering, unfortunately.
Right. So bottom line, take good care of those shoulders and elbows. That's what we need to be doing, right?
Right, exactly.
So I'm going to get started on the questions then. And the first one is from Carmen. And they'd like to know, is there a recommended limit for the number of cortisone shots that one should have? Great question.
That's a great question. I guess I get asked that all the time. And you
Yes.
know what? You know what? It's embarrassing to say this, but most doctors won't. And that is that we don't know. So, so it depends on your situation a lot, but I think there are some animal studies done in rats where, they injected cortisone into the joint or into the tendons themselves. And if you do enough of it, it will eventually cause, well, let's put it this way, it doesn't slow down the process that you're taking it for. So in other words, it doesn't heal anything. So in other words, if you have arthritis and you have a cortisone shot, it may get rid of your pain for a year, but you still have arthritis. And the same is true with painful tendinopathy, we call it. You may get a cortisone shot, but it doesn't really change. It doesn't heal anything. It's just it gets rid of the pain and the inflammation or irritation. I have some patients who have shoulder arthritis. Again, of course, it depends on the condition you're getting the cortisone shot for. If you're getting it for rotator cuff type issues, I think you have to be cautious and have a diagnosis. I think to just keep giving cortisone shots around your tendons or in your bursa probably does over time weaken the tendons, but there's really no science to say that 2 shots is too many or 10, and the same is true for arthritis in your shoulder. I have several elderly patients who just do not want their shoulders replaced. And even though their arthritis is terrible, and they come in every 4 months and get a cortisone shot. And I think it all depends on a lot of factors like what your goals are, how bad your pain is, etc. The downside with cortisone shots generally is, and we're not sure why this happens, but usually if you have a cortisone shot that really does a great job, and then you have another one 6 months later and it does a little bit, maybe not quite as good, and then 3 months later, maybe not so good, and after a while they don't have any effect at all. And so that's about the only thing you can say about how many is too many. But really, oddly enough, there's no scientific evidence that says you can have 2 shots a year, or you can have 8 shots a year, or whatever. So I always tell my patients that whoever told you how many shots uh, you could have, there's no literature. There's really very few scientific studies that say 4 is too many or 6 is too many. I think you just have to, if you're having to have that many cortisone shots, you probably should address the problem. But that's kind of a long answer to a short question, but it just demonstrates how there's not a lot of science in in cortisone shots.
Well, would you say though that having too many cortisone shots, because this is, kind of out there, you hear about this, that too many cortisone shots can start to break down the tendons, besides, helping them out maybe initially, but in time, I know, patients do hear that quite a bit. Is that sort of a myth, or is there data on that it can break down the tendons?
Yeah,
Not
well,
just, not just necessarily in your shoulder, but in your body, because it's
oh yeah, oh
systemically good for
absolutely.
your body.
Yeah,
Yeah.
absolutely. We know that if you inject big tendons like your Achilles or your patellar tendon, if you inject those, they see a lot of stress, and it probably does weaken big, huge tendons like that. And clearly, there puts people at risk for them to rupture. Oddly enough, the rotator cuff, when you inject the rotator cuff, you don't really inject the tendons, you inject the bursa around it.
Mhm.
Whereas those studies were done injecting it into the tendon itself, and so yeah, I think that big tendons in your lower extremities probably shouldn't. Well, not probably. You should never have them injected. The rotator cuff is a little different story. The same is true with your lateral epicondyle or tennis elbow. There's it may cause the tendon to generate over time, but nobody knows what that time is or how many shots cause it. So again, it's best to be judicious about it, but you can't really define judicious, you know.
True.
So
Yeah. It's true though that usually when people go and they're getting a cortisone shot, most doctors, they'll say, you can get, maybe two a year, every 6 months, or, that's kind of maybe a protocol. And what you just said earlier about the rotator cuff it seems like it's a little bit different than, the lower extremities when you're using cortisone shots, which is what you just said. So I guess it's
right,
kind of a
right.
case
Well,
by case. And also, I suppose if you have any autoimmune
right,
issues, you need
right,
to be, careful, I would imagine, with
right,
cortisone, right?
right.
Yeah.
Right. Yeah. So you're right. There are lots of factors that determine it. And a lot of it's like, say, your activity level, et cetera.
Right. Well, thank you for that. That's great. Okay, let's get to Cindy's question. And she'd like to know, are there any warning signs that the seat of your pants is wearing thin? And also, is clicking and popping in the shoulder a bad sign?
Clicking and popping, generally, a lot of your joints pop and click. And usually you don't notice it until you like hurt the joint or something, like your ankles. Everybody's ankles click and pop. I mean, and your shoulders, same thing. I always tell people, it may click and pop, but if it doesn't hurt, don't worry about it, because it could be. The other thing too is some people like their shoulder blade clicks, and they think it's coming from their shoulder joint or whatever. So in the shoulder, it's really difficult to figure out what's clicking and what's popping. Primarily because a lot of the parts are down deep in there. But if it doesn't hurt, don't worry about it.
I gotta love that. She'd also like to know, are there any warning signs that about the seat of your pants? What is it wearing thin? Excuse me, I'm gonna say it again. Are there any
Well,
warning signs that the seat of your pants is wearing thin? There it is.
yes, exactly. Well, usually people that come to see us where they like work in the garden and they got
Mhm.
their shoulder all irritated and they get an MRI and it shows they have a torn tendon. And usually people that seek treatment that have these kinds of tears that had like pain like that for a day or so 15 years ago or 10 years ago, or they fell 15 years ago and it hurt for a couple weeks and they didn't do anything about it, or
Mm.
or maybe they didn't even have a fall. And usually people will say, yeah, I did have this thing, 5 years ago where I had to ice it and take some ibuprofen and it went away, but that's the thing that's so crazy about it, is that, they'll remember something like that, but they never did enough damage to really put a hole in their tendon, I mean,
Sure.
and so, yeah, so it's for a lot of people, it's very surprising. I'm telling you, the thing about the thing where they put the luggage in the overhead bin, there's all sorts of stories where somebody picked up a 6-pack of Coke and they felt a pop, or they felt something go, and you know, and it's just because their tendons got thin enough to the point that they weren't going to take it.
Yep, it just
And
hit that magic moment of I've had enough. That's it,
right,
right? That's what it sounds
right,
like. It just
right.
over time, it just it just happens.
Yep,
Yeah.
it's very frustrating.
Yes, yes, I would have. It is. Okay, thank you for that, Dr. McFarland. Our next question is from Susan, and she'd like to know, are there any exercises one can do to prevent shoulder injuries?
Uh, Probably, I always tell people that if you're short on time, you're best spent your time doing aerobic activities. And aerobic activities are, walking and stair climbing and, you know, uh, biking, things that get your heart going. Uh, weights, weights are purely anaerobic. And so if you're going to do any lifting or weights with your shoulders, don't get carried away. I mean, you're better off spending your time doing aerobic things. But for your shoulders, the best things are some exercises that are down low that you can do relatively easily, like your internal external rotators down low like this, and you can do biceps triceps work. You can do shoulder pinches. You can do shrugs like this. But whatever exercises you do, you should do down low, because there's really no advantage to your shoulders to be doing military presses or presses with your arms real far away. You can get your arms and your shoulders in shape without these exercises that are actually very stressful for your shoulders. So it's in that situation, it's best to have a trainer or somebody who understands shoulders, and or a therapist. And but yeah, I think a steady. I usually recommend people you should stretch every day in the shower, just to make sure that your shoulders aren't getting stiff. And then if you do have an organized exercise program, you should do exercises that keep your arms below shoulder level. And some of the machines are good. What's really weird about shoulders is military press is really stressful for your shoulders, but lat pull downs are not. So there's some parts of it that don't make sense, but you should pretty much avoid, again, things far away from your body and things over shoulder height.
Right, and everything in moderation. You know,
Exactly.
this, how long what is your definition of recovery? Let's say you go to work out and you do a weight workout, or you're doing even yoga, or you're doing Pilates. What did you consider recovery times? 24 hours, 48 hours?
Yeah, I think it all that's highly individual dependent,
Mm-hmm.
and also what your physiology allows. I think anybody that works out a lot, they kind of figure out what hurts and what doesn't, and basically, if it hurts, don't do it. The old motto, the old motto of no pain, no gain. The motto should be no pain, no pain.
No
You
pain, no,
know.
right. So as you're maturing,
Yes.
you may have worked out 5 days a week or 7 days a week, even when you were younger. But as you're maturing, perhaps the 5 days a week doesn't work anymore. You might need a day off in between when you start to
Right.
feel a few
Right.
of those aches and pains. Because what I'm hearing from you is it isn't just about, your exercise, it's your everyday life. So you're constantly using your shoulders, and what you were saying that by your 30s, you've used them pretty well. So when kind of like from 40 on, it's You got to start to, maybe be, aware of what you're doing and perhaps don't overuse them like with the weights. Again, because your everyday life, you need to be using them. Just
Right,
getting
right,
dressed, doing anything. Yeah.
right, right. Well, I think doing a weight program with your shoulders as part of a general fitness is perfectly fine, but it shouldn't be done to the point that you're having a lot of shoulder pain or neck pain,
Mhm.
tennis elbow kind of stuff. And so it's, again, like you said, it's about moderation.
Yep. Agreed. Okay. Thank you. Our next question, let's see, is from Paula. If you have a bone spur in one of your shoulders and that shoulder hurts, but not constantly, are there particular exercises that would be useful if an x-ray has been taken and ruled out any surgical needs?
Well, what she's alluding to is there's really two theories about rotator cuff uh, degeneration or tears. One is the sort of intrinsic uh, theory, which I discussed, which means that over time, the tendons just get thinner and thinner. They sort of get older and older, and eventually there's a hole. There is the other group of thought, which has been sort of the predominant thing since about 1970 or so, which was called impingement, where when you raised your arm, the rotator cuff hit a spur or something, and that caused a hole in the tendon. And so there's still debate in our meetings and among other people about, what needs this or that. Most of the studies show that taking spurs off may have some surgically may have some advantage, but by and large, the big question is it chicken or egg? I mean, did the tendons getting irritated or getting thinner cause stress to the bone area, which creates the spur, or does the spur create the problems with the tendon? And so, by and large, though, spurs in the shoulder are very common, and uh, the exercises for them are designed to sort of stabilize your shoulder blades and that sort of thing. But the things, again, that are really hard for your shoulder in that situation are weights above your shoulder level, away from your body, or full body weight. So, it may not have answered your questions, but uh, if you have a bone spur and you've done all the things that we've kind of talked about here, and you've seen a health professional, then getting further studies is reasonable to see what the status of the tendon is. But again, it depends on how much it bothers you and those kinds of things. So to say, you got a spur, you should get an MRI right away. Almost everybody over the age of 50 has a spur around their shoulder, so um, the presence of a spur alone isn't enough to seek treatment.
Right. And perhaps like if, a good trainer, if they're working out with or PT, they could ask them, which exercise would be good for them to, they have this bone spur, but what's a good exercise for them to
Right.
strengthen? Yep. Right.
And that's again the situation where you take the ice after you work out, maybe take some ibuprofen,
Mhm.
et cetera, and I think the therapy, those things all mixed together usually take care of it.
Right. Great. Thank you. Our next question is from Katie, and she said, regarding your slide about avoiding raising your arms above your shoulders. So she says, then how can you maintain flexibility and range of motion if you can't lift them over your shoulders?
Well, I want to clarify that you can stretch over shoulder level, but you shouldn't lift over shoulder level. So it's one thing to raise your arms up like this. It's another thing to take dumbbells and do this,
Mhm.
and so it's you should stretch up here. So you should be able to get your arms to your ears. I'm getting stiff here. I got to start working on that. The uh, but
Get into
it's
some
okay.
yoga classes there.
I think so. So you can stretch up there, but you shouldn't lift weights up there.
Yep. Thank you for the clarification. It makes total sense. So yoga classes, they do quite a few things. That's stretching and all that. They do quite a few exercises over your head like that. So I would imagine, something like that those are great classes to jump into or to help the range of motion there.
Doing yoga and things like that, where it's just your arms, is really okay. But the second you put weights in your arms, you should try it. I mean, if you take a handheld weight and do this, and you take a handheld weight and do this, you'll immediately see the difference.
Right. And even these little 2-3 pound weights, they get heavy after a while when you're doing classes like that. That's a very good point because, a lot of women, myself included, we take a lot, classes. And it's not designed for an individual. It's designed, kind of for in general. And you really need to pay attention. I would imagine that you start to feel even those little 2-3 pound weights, but you start to feel a little twinge or something in your shoulder. It's like, okay, drop the weights. Don't need them. Yep. So, okay, our next question from Deb. What is the first diagnostic test for shoulder pain? And will that test show if someone has arthritis versus a tear?
In the shoulder world, the standard of care is to start with just a regular plain radiograph. Because it really gives you a lot of information about how much arthritis you have or don't have. And it also shows, your rotator cuff tendons, particularly the one that raises your arm, runs in a little space. And if that space is real narrowed, you don't need an MRI. You know that there's a torn tendon there. So the next step, obviously, after regular X-rays would be an MRI. So I think that to go straight to an MRI, usually the trouble with MRIs is, radiologists describe what they see, and what they see a lot of times is, it's really difficult to understand what that is if you're a civilian. We have a thing called a patient guide to how to read your shoulder MRI, because patients come in with the same questions, and MRIs, I can just tell you almost every MRI in somebody over the age of 50 is either painful. There's actually either tendinosis or a partial tear. They've got biceps inflammation. They've got a slap tear where the biceps attaches to the top of the socket. They've got labrum tears. They've got possible arthritis. And, the radiologist is just saying what they see. And oftentimes what they see is lots of stuff. And lots of that stuff oftentimes has nothing to do with what your pain is or isn't. And so MRIs can create a lot of angst. And so I think it's real important to realize that they're gonna call every little thing they see, but probably 95% of them aren't part of the problem.
Right. Makes sense. Okay, we just have a couple minutes left, so I'm going to ask. This question keeps coming up. There's like 3 of them, so I'm going to just combine it. So, what causes frozen shoulder, and what should you do to, try to get out of it? Once you have it, what should you do to try to relieve it?
There's 2 kind of things that are real important to distinguish from each other. One is a stiff shoulder, and that occurs when you have an injury. So say you fall and you break something, and then your shoulder gets stiff. That's not really a frozen shoulder. We call that a stiff shoulder, because usually the scar that's formed is a little different than when you have a frozen shoulder. The hallmark of a frozen shoulder is you wake up one day and it just hurts for no good reason, and you notice that you can't move it as far, and it's kind of achy. And then that can get worse and worse, and it just comes on for no godforsaken reason. And so, the key to that, though, is to try to make sure that you maintain your range of motion as soon as possible. And, again, try to get your pain under control with ice, maybe some anti-inflammatories or Tylenol if you can. If all that doesn't work, then you should probably see a physician or a therapist. Frozen shoulders are real frustrating for everybody, and you just have to be on it as soon as possible. The one thing I hate telling people this, but if you had a frozen shoulder, you got about 20% of people who have frozen shoulders get it on the other side. So you have to be really alert to the symptoms of pain and stiffness that are part of a frozen shoulder. And you just have to be on it.
Listen, thank you so much. I'm sorry, we're almost at the 8 o'clock hour, but that's very interesting to information this evening. And I would like to thank Dr. McFarland for speaking with us this evening. And Dr. McFarland has graciously agreed to answer any of our outstanding questions. So in a couple of weeks, you'll receive an email with the answers to these questions. If you want to rewatch or share a video of tonight's program, visit the A Woman's Journey website, hopkinsmedicine.org/A Woman's Journey under Videos on Demand. Tonight's program will be available by May 1. If you have enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey for more information about live programs, webinars, podcasts, and our monthly emails. Good night and stay well.